Thank you for inviting me to give this presentation today. I have no specific disclosures to address today, but I do want to acknowledge how much I appreciate the support from the Melanoma Research Alliance. As I'm going to describe to you in the next few minutes some of my prior work describing how hard it is to get an accurate diagnosis of melanoma, I think you will understand why I'm now moving my research towards artificial intelligence and trying to see if we can get computer tools to help improve the quality of our diagnoses. This is an outline of my presentation. I'll start by talking about diagnostic variability in medicine, and I'm even going to share my own personal story. I'm then going to move on and describe in depth one research study to give you a sense of how hard it is to do this kind of research. I'm then going to briefly discuss potential reasons for variability in the accuracy of some of our diagnoses. And then I'll culminate with a few comments on the potential and the need for artificial intelligence to help improve the quality of how we're diagnosing melanoma. I like this quote. Martin Fisher said, "Diagnosis is not the end, but the beginning of practice." And I want to explain why, in that everything revolves around a correct diagnosis. For those that are interested in prevention and in screening, when you have tissue samples to see whether your screening is effective, those pathology diagnoses need to be correct. If you're using imaging, such as CT scan or mammograms for screening, those diagnoses need to be correct. For those of you that have had loved ones or family members diagnosed with melanoma, you know you want to get that diagnosis correct to make certain you're on the right treatment. And then, of course, after you've had the diagnosis, you want to make certain the surveillance is accurate. For many years, I've studied diagnostic variability in medicine. I started out in breast cancer, and this shows an example of a mammogram, both the right and the left breast, with an arrow showing a suspicious lesion. When I took this same mammogram and showed it to 10 different radiologists, I received many different diagnoses, ranging from normal to suspicious of breast cancer. There's a lot of information in medical images, and it truly is an art to try to differentiate the important components from what is not important. It's not as bad as a Rorschach ink blot test that I show you on the right, but it is very challenging. I want to share with you a personal story that has relevance here. Years ago, my dermatologist called me at 7 o'clock on a Friday night and said, "Joann, I hate calling patients on a Friday evening with this kind of news, but..." Now, I'm a physician and I make these kind of telephone calls to patients, so I had a sense of what was coming. And indeed, I was told that I had potentially invasive melanoma on a skin biopsy. We decided to get a second opinion to look at the tissue, and the second opinion came back, it's totally benign, sort of a moderate dysplastic nevus. We then got a third opinion from a third pathologist, and the third pathologist said it's a Spitz nevus, not invasive melanoma and not a benign lesion. So I was stuck with a single skin biopsy that had 3 very distinct and different diagnoses. This is, you could say, when I had that aha moment, and I realized for years, all of my research in cancer screening and accuracy had been making the assumption that that gold standard pathologist diagnosis was valid and accurate and reproducible. And I decided at this point, wow, I needed to study this. So I then jumped right into studying pathologist. Of course, given my experience in breast pathology and breast cancer screening, my first study was looking at breast biopsies. And when I took a few hundred breast biopsies and showed them to many, many different US pathologists, we found that 1 in 4 breast biopsy interpretations were not in agreement with an expert consensus diagnosis that we use to define the accurate, correct diagnosis. Now, obviously, this was met with a lot of angst and concern in the media. And some of the comments that were typed into the New York Times, I thought you would be interested in seeing. One person, maybe they were a pathologist, they said, "This is a little like saying water is wet." Another person said, "If you think this is bad, you should study melanoma." Well, I did. And I had the pleasure of working with a very large melanoma pathology study team, many students, many world experts. And I want to walk you through the study. The goal was to quantify the accuracy and reproducibility of pathologists in the diagnosis of skin biopsies of melanocytic lesions. We had 240 cases. We used random sampling and actually added more cases in the middle of the diagnostic spectrum. In other words, we had some normal cases and some cases that were invasive melanoma, but we added some cases of melanoma in situ and those middle diagnostic category cases. We then brought in 3 world experts, and these experts reviewed all 240 cases. And then we had a consensus of the experts that we used to define the reference standard. We used what's called a modified Delphi method. And this is basically a method developed at RAND. And I'll show you here a bit of what it looked like. This shows 3 of our world experts in dermatopathology looking at a case that they had all independently interpreted, and they're trying to come up with a diagnosis. And you'll see one of them scratching his head. And it was a bit like a Mad Hatter teapot party. And indeed, Lewis Carroll, who you'll notice the theme woven throughout this talk. Lewis Carroll was a mathematician and was very careful with his use of words. And he once said, "When I use a word, it means exactly what I say it means, neither more nor less." We realized in these expert consensus meetings that the experts were using many different labels that kind of meant the same thing. And so we proposed a classification system called the MPATH-L that categorizes skin biopsies into everything from a class 1 that are just mildly dysplastic where no further treatment is required to the class 5 thick invasive melanomas. This would greatly help, I think, patients and the primary care providers who are getting these pathology reports that I'm an internist, we have a hard time interpreting these pathology reports ourselves. So a little bit more on the study design. The pathologists were recruited from a national source. We had over 250 physicians that volunteered to help out. We used the original glass slides for each of the skin biopsies. Now, to give you a sense of the logistics of doing a research project like this, only one pathologist could look at the cases at a time because we used the original single glass slide for each case, which meant that I would have to schedule a participant. They'd have to decide on what week they want to look at the cases. I'd have to mail them the glass slides, give them a week, and then have them mail them back. I'd clean them up, reorganize them, and send them to the next person. This took about 3 years just to gather the data. We had the pathologist interpret all of the cases in phase 1. We then gave them about a 6 to a 12-month washout period. And in phase 2, we sent them the same exact cases, but we did not tell them that they were seeing the same cases. I want to pause here and just say how much I personally, as a scientist, appreciated the commitment of the participating pathologist. We didn't pay them to do this. Pathologists care about getting the right diagnosis, and they were very vocal in telling us how hard it is to correctly diagnose these melanocytic lesions. They wanted to help us, and I am indebted to all 252 of these pathologists. Now, remember I mentioned how we came up with this MPATH-L classification. This slide explains why. Basically, I show a single case on the left, what the image looks like, and then on the right, this same case was interpreted by 36 different pathologists independently. And you'll notice there's lots of different terms that they're using on the same single glass slide. Everything from one person calling it a common nevus junctional to a few people calling it a dysplastic nevus mild, to at the bottom, some people are calling this case invasive melanoma. And it's because of this diversity in the language that was used that we came up with our MPATH classes. So now let me show you in a little simpler format the same results, but when they're lumped into these classes, you'll see that 7 of the participants interpreted this case as benign, all the way up to 4 of them interpreted it as a thin invasive melanoma class 4, and one person diagnosed it as an invasive melanoma. Now, the expert consensus on this diagnosis was moderately dysplastic. This shows only a single case, so now let me share with you the results for all 240 of the cases. This is from the phase 1 data, and on the x-axis going from left to the right, you'll see on the left-hand side the results for all of the class 1 benign cases. Then on the far right, you'll see the results for the class 5, the thick invasive melanoma cases. Now, what the y-axis is how accurate they were or how concordant they were with the expert consensus reference diagnosis. And you'll see for the class 1s that pretty much all of the interpretations were in agreement and they were correct. And you'll also see on the far right for the thick invasive class 5 invasive melanomas that more than 75% of the interpretations were correct. But as you'll notice, the pathologist did not do very well in accurately diagnosing moderate dysplastic nevus, or even the class 3 melanoma in situ, and then the class 4 thin invasive melanoma, that was just barely above 50% agreement with the experts. Now, remember when I described the methods, I said that we had a phase 1 testing and a phase 2 testing, and we gave each pathologist the same exact glass slides in both phases. We therefore have data on what's called intra-observer agreement. This is how reproducible are they? If they give it a diagnosis in phase 1, do they give it the same diagnosis on that case in phase 2? I'm using the same format as I did earlier, but again, this is intra-observer concordance. And again, you'll see on the x-axis on the left to the right, class 1 benign cases to class 5 on the right, that most of the time they were above 50% agreement with their own previous diagnosis. In other words, in phase 2, how often do they give the same diagnosis to a case? That they gave that same exact case in phase 1. But, you know, this isn't ideal. It would be nicer if the pathologists were more reproducible. And this, I suspect, will get all of you thinking that, well, at least maybe the computers with artificial intelligence and support will be more reproducible. Now, no study is perfect. And when we published this melanoma pathology study, some said, well, this is just predictable disagreement. And others said, not everything looks like the textbook. But, you know, obviously this was used of a testing situation. Ideally, I would have loved to take a case and sneak it into the day-to-day practice of pathologists. But in order to do that, with 252 pathologists that are practicing throughout the entire US and that have many diverse different types of clinical practices, that is just not feasible. Other limitations are listed here. Perhaps the most important is the bottom one, which is that the underlying biology is unknown. You know, we want to know which of these skin biopsies is going to go on to harm the patient, and that is not known. Now, for part 2 of this presentation, I said I would briefly mention all of the many reasons for variability when physicians make a diagnosis. And here we have variations in the age and extent of solar elastosis for some of the cases. For the providers, we had over 250 providers with quite distinct different skill levels and levels of experience. Some were board certified, others weren't. Some had been in practice for many years. Some had been sued for malpractice and perhaps were more worried about missing things. But we also were interested in considering what health system issues might be relevant in regards to variability, and also to think about how to improve and reduce that variability. So we've also studied second opinions and even computer-aided tools. Now, moving on to part 4. At this point, I begin wondering, what more can we do? Obviously, I've shown in my prior work that getting an accurate and reproducible diagnosis is prone to error, and it is very challenging. These melanocytic skin lesions are of the utmost difficulty. So at this point, I began seeking ideas for where my research should go. And at this point, I ran into an article published in PLOS One, it's a medical journal, and this is a pigeon that was taught to interpret biopsy cases, and the pigeon was able to tap the screen either blue or yellow based upon whether the pigeon thought that cancer was present. And the pigeon was fed, you see on the left, those are little food pellets. The pigeon was given food pellets for a correct diagnosis. And I can basically tell you that the pigeons did quite well and were quite accurate, almost as accurate as the pathologist. And at this point, I thought, oh my goodness, I need to pay more attention to how we humans are making the diagnosis and what goes into it. And so I started by studying eye tracking. And this shows historically how hard it used to be to take a human being and see where their eyes are looking. But it's now much easier. There's a contactless eye tracker that you can see on the bottom right. And this shows a pathologist on the left looking at a case. And this pathologist's eyes are being tracked while he looks at a case and interprets it. Now, we actually have gathered lots of data. On the top is a computer screen. And on the bottom, this shows you the entire glass slide contents. And you'll see how the pathologist rotates around and looks at different areas. And I'm able to gather concrete data from the records of all the viewports. In other words, I have the case number, the log time, how much time they spent, whether they zoomed in or out. And we can look at all of this data to try to understand what are the human pathologists really looking at. Then, as I did further research, I found a few different patterns. This shows one pathologist looking at a case. I call this person a scanner. It's like they're mowing their yard. On the left is the sort of graph of their behavior. On the middle is the viewport. And on the right, you'll see what they actually see in their screen. And so I call this person the scanner. Let me now show you comparison with a different type of viewing behavior on the bottom. This person I call a driller. This person definitely just zooms out, sees where they want to go, and zooms in. Given this much variability in the behavior, the question is, what is the best approach? And that's something that I'm currently investigating. Now, this all brings me over to trying to pull in support tools. I have appreciated the funding support from the Melanoma Research Alliance, and I want to just walk you through on a single slide some of the work that we've done to try to develop computer-aided detection tools. On the left is an image of H&E glass slide. It's a whole slide biopsy image. And first of all, we had the computer identify the region of interest for this slide. Then we used what's called a convolutional neural network to take the region of interest and we segment it into all of the different types of tissue that you see color-coded, whether it's red for necrosis or yellow for blood. We then take this data and we use what's called a support vector machine. And this support vector machine then is able to take all of the image information at a pixel level and come up with a classification or a diagnosis of atypia. It's a bit like a black box, but increasingly we are seeing a lot more of these publications, and the computers are doing really well. But there's a few challenges. First of all, as I look at the increasing number of publications on the use of machine learning and artificial intelligence, I realize the variability in the data that is going in. Obviously, the data going in needs to be representative and not biased, and representative of all of the patients in the US. That's not always the case. Secondly, sometimes these studies, what they're using for a gold standard may not be gold. They may be using just a single pathologist diagnosis to define the diagnosis. Remember, I showed you how much variability there is among pathologists in the diagnosis of some of these cases. You know, we used 3 world experts to define our reference diagnosis. And then the final area that concerns me with all of these many new AI tools is how we will integrate them into clinical practice. And what is the clinician in our day-to-day practice? How do we use that data? I will admit that I am a bit of a skeptic, and I want to explain why. This stems from the fact that I'm a physician, and years ago, one of my clinic patients asked me, I was working at a county hospital volunteering, and the patient was bothered because she saw an extra charge of $65, and she says, for an extra computer thing on my mammogram. Well, this patient was talking about an extra charge for computer-aided detection that was added to her mammogram. And I thought it was a good question. Is this helping? And I happened to, at that time, as I told you, I was working in breast cancer screening as part of my research. I had access to a very large database. And we did a study where we looked at the accuracy of whether this computer-aided stuff in mammography improves the accuracy. You'll see a figure here on the left, and only 2 lines, a black line for the results where there's no computer-aided detection, and a red dashed line when the computer-aided detection was added. And the red line is lower. That means that it has lower accuracy. So in other words, in this study, we pointed out significant drop in diagnostic accuracy when the computer-aided detection tool was added. My hypothesis is that the radiologist, they saw so many different marks on the mammogram image that the false positive rate went up. They started calling back more and more patients for additional testing. They didn't want to miss anything. My other hypothesis is that perhaps they became a little, how do I say this? They became reliant on the computer tool. And we noticed that they were missing some of these lesions that they probably would have picked up on if they weren't relying on the computer to back them up. So given my background here, I have continued in this research area, and I want to summarize with the following 3 points. I hope, first of all, that as I described the results of hundreds of US pathologists trying really hard to interpret melanoma and melanoma in situ, that providing that diagnosis is challenging. And sometimes these diagnoses are neither accurate nor reproducible. Skin biopsy lesions and melanocytic lesions are really challenging. And as a researcher and also as a clinician, we have to navigate this seemingly other wonderland. There's variability in language that the pathologists use when they describe these lesions. There's variability in how pathologists are even looking at cases and in the behavior they use to interpret them. And now we have these new tools coming out from artificial intelligence and machine learning. And we need to be cautious and careful, and we need to make certain we study them before they spread to broad use, because they could potentially have lead to problems. So at this point, I want to thank you very much again for inviting me, and I look forward to your questions.
Thank you, Dr. Elmore, for what a fantastic talk. I personally found so much of that shocking and almost a little scary. But I'd like to now take a few questions from the audience. If you have a question, please submit it using the Q&A toggle on the right-hand side of your screen. For our first question, Dr. Elmore, I'd like to ask, someone typed in, my mom has just had a skin biopsy. How can I make certain that she gets the right diagnosis?
Great question. I guess I would suggest doing what I did when I had my own experience over a decade ago. First of all, research has shown that pathologists who have specialty training and board certification, they provide a higher level and more accurate diagnosis. There are general pathologists, and then there are pathologists that do an extra year of dermatopathology training. And that, I think, gives you a slightly higher quality of diagnosis. I will add, though, that these are just really challenging to diagnose. And all pathologists care, they want to get it right, but they're really challenging to interpret. The second suggestion I will make, in addition to who interprets it, is to get a second, maybe even a third opinion, like I did. You have a right to access your medical records. You should be able to sign up for the patient portal, and you should be able to read your own skin biopsy results. And then I hope that some of you in the audience will help us. We need to get the world to improve the pathology reports. We need them to be standardized and simplified, just like we do in breast cancer screening, so that the reports say it's normal, don't worry, it's melanoma in situ, get a certain amount of tissue margin versus it's invasive melanoma. It would make it so much easier for you, the patient, but also I'm a primary care doctor and I have a hard time interpreting the pathology reports myself.
And then Dr. Elmore, one of the questions that we get this a lot actually is what accounts for the differences in time? So sometimes when you get a biopsy performed, you get results later that day, later, maybe the next day. Other times it can take weeks. Do you know what goes into that process and that disparity in amount of time it takes?
Yes, I do know what goes into it. And I also know how frustrating it can be waiting for the results. Not every place that does the biopsies has the services to, the formalin, to make the small cuts on the biopsy chunk and to put it on a glass slide, to stain it. And not all of them have the in-house expertise of a specialty trained pathologist. It may take them a few days to both make the slides, get the slides physically to the correct place where someone can interpret them. And then I have to say that when it's a challenging case, they then will say, well, let's get an additional type of stain. Then that requires going back to the tissue block, cutting it up, using a different type of stain, and then reinterpreting with the new information. So sometimes it can take quite a few days to weeks.
Mm-hmm, mm-hmm. And one of the other questions that we're getting a lot is, do you see variation between the accuracy of a diagnosis made at a major cancer center compared to those made in maybe a community clinic?
Yes, I do. So I suggest getting second opinions.
Yeah. I think that is definitely the theme that I'm taking from this. And another question is actually related to the study that you performed when you sent the samples out and then 6 months later resent the same samples. Were those pathologists or dermatopathologists?
We had both. These were US pathologists that are currently interpreting skin biopsies. So it wasn't residents or medical students. And about half of them were specially trained in the fellowship and board certified. And we actually have shown that those that have the specialty training had a higher level of accuracy compared to those that didn't in our study.
Wow, yeah. And then kind of a different take on a question that we already had, and that's for folks who live really far away from a major cancer center. When it comes to looking at a biopsy sample, is that something that can be sent through the mail? Like how can someone go about that if they live just really far away?
Two answers. One is yes, the glass slides can be sent through the mail. In fact, that's what I did for our study. We shipped them. It took many years to the 250 odd different pathologists. So you can get them shipped to a second opinion, but we now have new digital technology. The FDA has approved use of these machines that you put the glass slide in and it will scan the image so you can send it electronically. And just as we have telemedicine, we're soon going to be having dermatopathology. It's coming. It's not yet here yet.
That's very exciting. And I guess another question that someone just posed is, in the sense of the timeline of when things happen, is it actually possible to get a second opinion on your initial pathology results after surgery, knowing that these slides are preserved somewhere?
They are preserved somewhere usually, but not forever. So, keep that in mind. And yes, you can seek second opinions.
Great, great. And then kind of shifting gears a little bit, is you spoke a lot about how artificial intelligence might be able to bridge some of these gaps, work with our pathologist friends to really give people the best diagnosis possible. Do you care to forecast like how soon we might expect that some of these technologies could be seen in the clinic?
Boy, it's coming. We're seeing it in radiology imaging. We're already seeing it in breast cancer screening. We're seeing really promising results in lung cancer screening imaging with radiology, CT scans. And with pathology, there are early results that look almost as good as the pathologist. I don't think it's going to be here this year or next year. And yet, I also think that the bar to get approval for FDA is pretty low. And when you send something out to the large community, not all doctors will interact with that information in the way that maybe it was anticipated. And it may lead to lowering accuracy. And so I think they need to be studied before they get into regular practice. It's coming really fast, but not in the next few years. In other words, if you just had a biopsy and you're wondering, can you have AI interpret it since you're scared by my results? The answer is not yet.
And then someone actually just asked, the pathologists who were involved in your study, did you share the results, share their individual results with them so they could see that? And what were some of the reactions that you got?
We did. And it was a very unique and time-consuming way to share the results. We gave them individualized, confidential results, how they interpreted a case, to how all of their peers interpreted it, to how the world experts interpreted the case. It was educational. Many of them have sent thank you notes to us, and they felt like they learned a lot from it. But others said that, this is kind of what they expected. And that's why they got involved in the study, because they care and they want to try and help us figure out how to improve the accuracy.
Yeah, and then you mentioned a little bit about this and how everyone deserves the best diagnosis possible, but how can we make sure that there's not bias being written into the algorithms that we're now trusting to bridge this gap for us? We see time and time again when it comes to big tech, how these seem to sneak in there.
I have noticed that given the proliferation of publications on AI, it's like every week there's more papers. The data going into the development of the algorithms is not complete. It's not ideal. There's not good racial differences, and it may be too small of a sample. And that concerns me greatly. I also have noted that sometimes when these are approved and get used in clinical practice, there's a financial barrier that has to be overcome in order to pay the extra money for them. There have been publications showing racial issues with AI and machine learning. There was one, a very large machine learning algorithm that was developed that was based upon cost analysis of patients' care. And they found that it was doing a disservice to all of the Black patients in the clinics and in that healthcare system. So it is an important question, and I'm glad it was asked. And right now, I think we're still in the early stages of just developing the early AI algorithms. They then need to be validated in much larger, more diverse patient populations.
And then before I ask my last question, I'm curious if there's anything that you want to offer as a summary or takeaways for all the folks listening.
Well, I should say that I was also surprised and shocked by the findings when I told the audience about how much difference there was between multiple pathologists interpreting the same skin biopsy. I was a little bit appalled. I went back multiple times to make certain it wasn't a data error on my part. And as a physician and as a researcher, it makes me frustrated. We have to do better. And that's what's pushed me towards wanting to work with AI. And I really appreciate the MRA because you have helped kind of nudge some of us in new research directions. So thank you.
Well, thank you for what you do. And I would like to end on a maybe a little controversial question that our friend Jane actually posed a couple of minutes ago. And that's, how can you really trust a diagnosis? What would you tell patients so that they can trust that the foundation of all of their future care is correct?
Medicine is an art. As a physician, I'm constantly reminded that every patient is different. And that's one reason I love the practice of medicine. In our study, we had the individuals who have written the textbooks on melanocytic lesions, and we asked them to interpret the cases. And getting them to independently interpret and then getting them to get together to come up with an agreement. There was a multi-headed microscope where they all sit around it and make certain they agree. To me, that's high quality clinical care. And I should reassure the audience that most cancer centers, when you are first seen, with a new diagnosis of any type of cancer, the first thing we do is verify in a very high quality way. And they have tumor conferences where we bring in the dermatologist, the pathologist, maybe some people in basic research, and they review all aspects of the case. And it's that practice of medicine that we can trust while we're waiting for AI and other fancy genetic tools to help us.
Thank you. No, that's very helpful. And I know we've run out of time for today, but again, I want to thank you for the work that you're doing, for continuing to highlight where we're falling short, and then also giving us strategies and hope for how we're going to get there in the future. So thank you again, Dr. Elmore, for your time today.
My pleasure.